the referral is not reaching all the patients that are maybe eligible. So I think the statistics and what has been published is that about 30% of the eligible patients actually receive CAR T cells. And I just want to highlight in second line large B-cell lymphoma, about 50% go into long-term remission, are possibly cured through CAR T cell therapy. And we are not seeing these patients.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am your host, Isabel Oliveira. CAR T-cell therapies are now standard of care for several relapsed refractory hematological malignancies, and they are moving to earlier lines of treatment. But many eligible patients are still not treated. So we have here Professor Marion Subklewe, who is going to help us understand how patient referral works in Europe and why is this the case. So welcome. Can you please introduce yourself?
Yes, so thank you for the invitation. My name is Marion Subklewe. I'm a hematologist oncologist at the LMU in Munich, Germany. My focus is on cellular immunotherapy. I'm heading the program there at LMU. I'm happy to be here and join you.
Thank you very much for joining us today. So I'm going to start with something very basic. How is CAR T referral in Europe and how has it evolved since the early years when there was a very difficult access to this therapy? How is it now?
So I think the approvals have been around in Europe, the commercial products like Tisocell and Axicell since 2018. And I think the most common entity was third line refractory relapse large B-cell lymphoma. And at the beginning, it was very challenging to sort of build up the CAR T-cell program and also to inform referring sites and also to inform the public and patients about this novel treatment line. I mean, I personally have watched that for years. It was really eager to start it. So in the beginning, I think in a lot of European countries, we sort of built up the program, but had a hard time with getting suitable patients for CAR T-cell therapy. And maybe I was in Germany. In Germany, is a privileged country in that sense that we have almost all CAR T-cell products approved and also available. And that was also at the start of the CAR T-cell approvals. But we have a decentralized structure in healthcare. So we rely on the referral. And as it was in third line, the challenge in the beginning was that we often receive patients also in fourth line or fifth line. So if nothing works, then patients were referred, and clearly we got sort of the worst patients. That was a problem. It's very different across Europe, right from the start. For example, in the UK, but also France, they have a centralized system and they had national boards, very structured. So the referral was less of an issue, but they had sort of internal guidance what patients were actually suitable. And I guess we can talk a little bit more, but I think it has evolved immensely. If we go back to Germany, now that we have clearly more CAR T-cell products available, but also CAR T-cells, for example, large B-cell lymphoma in second line, it has largely improved. The national guidelines have been adapted. It is sort of common knowledge that is state of the art for early relapse, for example, in large B-cell lymphoma. So I think the acceptance, the knowledge, the information has greatly advanced and it has supported the referral system.
So the information is there, but how much variation is there across Europe in the proportion of eligible patients that actually reach CAR T?
Right. So I think what has improved is that patients get referred in the right indications. So for example, second line, that is actually happening. And in the beginning, it was really a very heterogeneous patient population that was referred. So the stringency has improved, but the percentage of patients that actually get referred and that are actually receiving CAR T cells is still depressingly low. So if you look at I think we have 31 countries in Europe. First of all, there's a great heterogeneity in the approval system. So there are still countries that have most of the commercially available CAR T cells not approved. We still have about half of the countries where we don't have second-line CAR T cell approved for large B-cell lymphoma. So that is clearly an issue. And then the second issue, in those countries where we do have approval, for example, in Germany, of all commercial products, the referral is not reaching all the patients that are maybe eligible. So I think the statistics and what has been published is that about 30% of the eligible patients actually receive CAR T cells. And I just want to highlight, in second-line large B-cell lymphoma, about 50% go into long-term remission, are possibly cured through CAR T cell therapy, and we are not seeing these patients. And I think sort of the best country in the setting of referral in numbers actually receiving CAR T cells is France, because they have the centralized system and they have structured referral and structural boards decision for these kind of patients. I think it's like almost 50%. So even in France, not every patient who is eligible, who has an indication for CAR T cells, is actually getting CAR T cells. And I think that is a huge challenge.
And so what are the main reasons that that you don't see these patients, that they are not referred in time to the right place?
Right. So, I mean, I live in Germany. We have 31 countries, and I cannot speak for all the variations of the different countries. But I think we can already talk about Germany, which, as said, has every product approved and is sort of a wealthy country. I don't know, in your debate, but it is still going sort of well. Why are we not seeing these patients? Maybe we start with Germany, right, where we have about 30%. So I think also how it started, referral was on a personal basis. Sort of people called the CAR T cell center, patients were referred. And in Germany, we are missing a mandatory structural board for sort of patients with specialized oncological diseases, where patients have to be introduced and have to be debated. So we have these boards, but we don't have sort of the requirement that non-CAR T cell sites and CAR T cell sites have a common board. So in a lot of sites, we have this hematological boards that are interdisciplinary, while we don't have a clear connection to referral sites, let it be non-academic hospitals or hematologists in private practice. So it's still a variability how the treating oncologist is handling the patient. And I think one of the challenges is, if you've never done CAR T cell therapy, you might have too much concerns in relation also to toxicity, and have the concern that maybe a patient is not eligible for CAR T cell therapy because you've read a lot about maybe toxicity. And then you have a patient, I mean, the average age, for example, for large B-cell lymphoma is 66, 67 at initial diagnosis. So often these patients are a bit older, maybe have some comorbidities. And I think that's one of the issues, that as we don't have these required structured boards that they do have in France, it relies on the personal assessment of the treating oncologist. So what I'm trying to propagate is really to have structured boards where we discuss together each individual patient that is refractory to first line, in the case of large B-cell lymphoma, or has an early relapse, right, defined as 12 months after finishing first-line treatment, that this patient always has to be presented at a CAR T site, because I think only CAR T cell experience physicians are able to decide if a patient is eligible or is not eligible, as I think almost none of our countries have made a clear list what defines a patient to be eligible or not eligible, right? And there's also no consensus in European or US on the definition, right? So I think that is, at least in Germany, a problem. So we actually analyze in our own cohort, because I was wondering if the patient characteristics of those patients we recruit from our own site versus the patient characteristics of the referred patients differ. So, and for this analysis, we learned two things. First of all, and when we look at the past 8 years, in the beginning, we had like almost 80% of the patients from our own side, and we had a lower number of referrals. Now, if we look right now at our site in Munich as an example, we have 50% from our own center and 50% referrals. So it clearly has advanced in the referral sort of doing or whatever. But when we look at the patient characteristics from our own side and from the referred ones are younger, fitter, and in better shape. So that I think is suggestive that people are still, or the treating oncologists are still a little bit hesitant to send the elderly patient with some comorbidities. So I think that is one part for a decentralized system. And I still saying I see the structured system has big advantages. If we then look to France, where they have the structured system, I don't know these numbers, and it's different, right? Because they have the structured system. But I think it's really helpful to have these common boards where every patient has to be introduced. And at least if you look at the numbers eligible for CAR T cells, like Germany has about 30%, France has up to 50%. I think these centralized structures are very helpful for reaching out to all patients.
So which patient factors? So you're talking about the systemic factors that prevent patients from being referred, but what patient level factors are preventing also patients being referred? Are they reluctant for CAR T?
Distance to a CAR T cell site might be an issue, that patients prefer to be treated closer to home and don't want to go drive 2 hours to a city. There's a large hospital, they don't know anybody, and get treated with some kind of gene immune cells or something. So I think distance can be an issue. I would say, for example, in Germany, you can reach a CAR T cell site within 1.5 hours wherever you live. So I think we have enough CAR T cell sites, and I actually don't propagate that each small hospital is going to do CAR T cells. And we know that to get better treatment, more successful treatment, if you go at a site that is doing whatever, might be surgery or CAR T cell is doing more often. But I think it still can be a limitation, and that people are reluctant or patients are reluctant. Then I clearly think that age is something that people think I'm not eligible for CAR T cell therapy because I'm 75, 78. And we know from the data that age is not a relevant factor and that the outcome is the same for the older patient like the younger patients. So that needs to be better communicated. And then clearly there can be comorbidities or patients are not eligible, and that has to be assessed by a physician that is experienced in CAR T cell therapy. But then I think very importantly, the locally treating oncologist, the communication between the oncologist and the patient and the oncologist and the CAR T cell site is super important, and that there is trust, that we don't sort of take away the patients coming from a CAR T cell center and refer back. So we need to treat these patients as one team and work closer together so that, for example, the lymphodepletion can still be done by a non-CAR T cell center, and that we only do our CAR T cells at a CAR T cell site and give the patient back to the local hospital as fast as possible. And I think that's better for the referring oncologist. He gets his patient back. And I'm very sure that the patient also is really happy to be closer to home, right? And in the US, they give a lot of outpatient CAR T cells, right? We are still very reluctant to do that, also because of regulatory obligations. It's not that easy to do that in Europe, but I think we need more flexibility. We need more networking and working together for the benefit of the patient.
At some point, there were not enough spaces, so it was very expensive. Not all patients that could have been treated were treated, but because of price considerations and availability, let's say. So now the availability is enough, and any patient that is referred to you and that qualifies for it, that really should get it, can get it. So that should not be a consideration anymore.
I'm sure that's very different between the different European countries. In Germany, every patient who is eligible for CAR T cells will get CAR T cells. Slot availability is not an issue. Everybody can be treated. But I must say that sometimes if it's a very aggressive disease setting, we still sometimes have to wait for a slot. It sort of varies a little bit. Sometimes also the slot for the leukapheresis can be the first sort of needle where we have to sort of wait a couple of days. But I think compared to the early days, it has greatly improved. I'm not sure if that's also because we have now all the sites in Europe for production, but I think slot availability has markedly increased, and at least in Germany, it's not really an issue. But, once in a while, there can be a patient with very aggressive disease where like every day counts, and then it can still be an issue. But I would say in general, slot availability has greatly improved.
So now the bottleneck is much more patient referral and knowledge and getting them to the right place at the right time.
Yeah, the transsectoral network, I think, and I personally feel CAR T cells could be a blueprint for all kinds of treatments, right? Where we need to better work together as academic university hospital and a smaller hospital and those in private practice. And some countries are privileged that they have this centralized structure where they're obliged to do so. Other countries, which are also privileged, like Germany, don't have this given structure, but we have to work together and get this transsectoral network going. And sometimes it's really strange, but I always wondered when I went to the US, if you watch TV, you see all these advertisements, for example, for immune checkpoints and so on. And I was always wondering, who are they advertising to, right? And sometimes I wonder if we would have advertisement on TV, right? Patients would be better informed and could ask their treating oncologist, is this a therapy that is suitable for me? And that's what I really like patient advocates, the involvement more of patient groups in treatment decisions, also in grants and clinical trials. And all these groups hopefully will also help to sort of distribute the information on these kind of novel therapies, also maybe on side effects and have a valid information on patient platforms and sort of spread the knowledge so that it's also something they can ask from their treating oncologists. And maybe lastly, we have initiated with EHA EBMT the Go-CART Alliance observership program within Europe, where an emerging CAR T-cell center can send a physician to an already established CAR T-cell center, and they come for 2 weeks and learn how to sort of do the CAR T-cell journey with the patient and all sort of logistics, but also the real problems and the toxicities. And it's meant to also to be like a mentor-mentee in a longer term. Sometimes I wonder if we have to expand this also to other healthcare professionals or even, involve patient advocate groups to sort of spread the knowledge that CAR T cells are not that dangerous or something and are suitable for most of the patients that are eligible and are possibly curative. So I think that's really important to communicate and inform on different levels.
So at the moment, the collaboration we're talking about is between health professionals. More people learn the technique, but we keep the patient from one country to the other.
We have been treating a lot of patients from European countries, particularly in the beginning where there was no CAR T-cell approval, that came to Germany and were treated at our site, mostly from Eastern European countries where there was no CAR T-cell approval. But I think that has changed, not to the extent we want to. I said, right, not even 50% of single-line CAR T-cell approved in Europe of the therapy that cures 50% of the patients. I mean, imagine it would be yourself, your parents, or somebody. It's really depressing. But in principle, I think patients shouldn't move, but we as healthcare professionals should exchange and learn from the systems from each other.
Is there something else that you would like to highlight for your?
I think that we have to sort of, in science, you say you have hero science or team science, right? So I think also in clinics and taking care of patients, you have to acknowledge that nowadays we need teams, we need networks to optimize our treatment strategy for our patients. And I really believe that the changes we hopefully can implement in the CAR T-cell setting, and I think probably it's a blueprint because it was a very novel therapy platform and had completely novel toxicities. And we really also have to acknowledge that there is long-term toxicity with CAR T-cells. And if you think of the numbers there have been with commercially products more than 50,000 patients being treated worldwide, plus all the non-commercial academic CAR T-cell products and so on. It's a large number, and they have a higher likelihood for infections. They have to be monitored for certain vaccines. They have the risk of second primary malignancies. And this cannot be done and cannot be watched out by the CAR T-cell center. So I think the referral to CAR T-cells, but also the long follow-up of CAR T-cell treated patients has to be done together, right? So we don't need a light tour of lots of CAR T-cells, but we have to sort of see the entire journey, and the journey is sort of hopefully lifelong as we cure more and more patients and more CAR T-cell survivors are gonna run around, which is great, but it also underlines that we need this transsectoral networking and that we need to work together. And clearly, because that helps, I would really appreciate if also politics and so sort of encourage and augment and financially support when we build up these structures for our patient care.
So thank you very much for this conversation. Thank you for being with us today. Thank you to the audience for listening. If you enjoyed this episode, please like it and subscribe to our channel. Stay tuned for more episodes of EHA Unplugged.